Okay, welcome everyone to the discussion of hypertension. Hypertension, we're going to divide it in a simple way. If it's in the outpatient setting, or if it's in the inpatient setting, or if it is urgency, if it's emergency. It's going to be interesting. Let's see, in the outpatient setting, what do we have? We have good calcium channel blockers, and we have ACE inhibitors / ARBs. And what else? What else do we have? What do you think?
We have arterial dilators
Arterial dilators,
and we have venous dilators.
venodilators. Okay, excellent. What else?
We have diuretics.
The thiazide. Excellent. What else?
We have aldosterone antagonist.
Excellent. Aldosterone antagonist. Ouch. Is that the aldosterone antagonist? And then what else?
We have beta blockers.
Beta blockers. Perfect. Fantastic. So the thing that have high efficacy calcium channel blocker and ACE inhibitor, the one that have moderate efficacy arterial dilator, venodilator, variable efficacy like in certain people, thiazide like mainly African American, aldosterone antagonist, usually different if there's depending on the cause. That's what if it's caused by adrenal disease, then you start aldosterone antagonist. Okay, so these are the things. Beta blocker have low efficacy in managing high blood pressure. Now we're gonna talk about the side effects and the benefits for each one of them. Okay, so the calcium channel blocker, what do you want to talk about first? Benefits or side effects?
I'm going to start with the side effects.
Okay, side effects. Okay, side effects could cause peripheral edema, but don't forget it helps anti-anginal. That's a benefit. It's anti-anginal. That's the benefit for it. Okay. Example: lodipine. Okay. ACE inhibitor herbs. What are the side effects for it?
It can cause acute renal failure if given to renal artery stenosis.
Okay. Cough could cause to angioedema. What else? Increase potassium. Increase creatinine. Sorry. Okay. What are the benefits? When do we use it? Or someone with congestive heart failure, right? And coronary artery disease.
And patient with diabetes mellitus.
Excellent, perfect. I love it. Thank you for adding this. This is very important one. Diabetes mellitus, for example, lisinopril and valsartan. Arterial dilators. Why? What are the side effects?
Hypertension.
Reflex tachycardia. That's the main thing. Okay.
Due to hypertension.
Yeah, because it affects the bar receptors. Benefits, we don't use it that much, so usually I think emergency we can use it, and short acting, so it's not good. Venodilators, however, what are the side effects for it?
Headache due to vasodilation.
Headache, and has benefit of what? Anti-anginal. That's perfect. Thiazide, what are the side effects? Hypokalemia. And what are the benefits? Salt sensitive, so decrease the salt. Aldosterone works the opposite of thiazide. So aldosterone antagonist like spironolactone works the opposite of thiazide, like blocks the thiazide channel. So what do you expect the side effect to cause?
Hyperkalemia.
Hyperkalemia, perfect. And when do we use it? In heart failure. Okay. And hyperaldosteronism. aldosteronism, what we call it. I think, remember Cohen syndrome, right? That's easy. Beta blockers, what are the side effects for it? Bradycardia, erectile dysfunction, and depression, because it affect your mood. What are the benefits for it though? To be used in CHF, coronary artery disease.
Chronic CHF.
Okay, yeah. Chronic CHF. Excellent, good job. Like metoprolol, carvedilol. Okay, these are the things that we use them. The calcium channel blocker, like the verapamil diltiazem, usually given for rate control for atrial fibrillation. That's not given for hypertension. Another thing, alpha antagonists like tirazosin, usually given for benign prostatic hypertension. Let's name them in others, just so that we don't confuse them. Others, like calcium channel blocker, heart selective.
So dihydropyridine, you mean to say?
Yep, heart calcium channel blocker, dihydropyridine. These are used for rate control. Okay. Another one, alpha antagonist, like tirazosin. It's good if somebody has benign prostatic hyperplasia plus hypertension. We can do that. And loop diuretic, what else? Loop diuretics. Okay, to affect the volume, there's a risk of hypotension. Okay. The other thing with beta blockers too, beta blockers that are non-selective, labetalol.
Like cardioselective.
Yeah, there's one that cardioselective metoprolol, and there's one. So there's different with beta blockers. There's difference. Like some of them have no alpha. Some of them have some alpha. Some of them have most alpha. Most alpha can be given like labetalol, given in end-stage renal disease. Some alpha like carvedilol, and no alpha like metoprolol. Doesn't affect the alpha channels. Okay. So these are the things. And the other thing, never clonidine. Why? There's never
Rebound hypertension.
Rebound hypertension. Okay. So you never treat it with hypertension. No, patient setting. Unless, now what are we going to talk about? Now, in the inpatient, what do we start with? What do we give in the inpatient setting? How do we treat hypertension in the inpatient setting? What are the options? We have clonidine. Okay, and what else do we have?
Labetalol.
Labetalol, excellent. What else?
Hydralazine.
Hydralazine, perfect. Okay, clonidine, you can start with 0.1 milligram to 0.3 milligram. Labetalol, 10 milligram. 10 milligram, Q 4 hours. PRN. And hydralazine, you can do 10 milligram, Q 4 hours too, same thing. Okay, systolic blood pressure, usually when the systolic blood pressure less than 180 and heart rate more than 90, or diastolic blood pressure more than 100. Okay, that's when you consider these things, like if it's very high. Now, what is the difference between hypertensive urgency versus emergency?
In urgency, we don't have any ongoing end organ damage.
Excellent. So this is basically the difference is that end organ damage. So this is emergency. The only difference is that if you put it
Ongoing.
ongoing end organ damage. Okay. Urgency, there's no end organ damage. So how do we manage? And the blood pressure usually in emergency, what is it? What is it? The value of blood pressure usually?
Generally, the systolic is greater than 180, and the diastolic is greater than 110 or 120.
So emergency either more organ damage, or 220 more than 220 over 110. Okay. So that's the emergency. What do we do? How do you manage?
We first send the patient to ER, admit him.
Okay, yep, we do that. And after that, we calculate the mean arterial pressure. It's an important. And then, second thing, we can do nicardipine.
If it is related to raised intracranial pressure.
Exactly, there's an increase in intracranial pressure. Or the second thing, we try to decrease mean arterial pressure to 25% low in 1 to 6 hours
Of the baseline.
okay of the baseline. We would decrease that. And the fourth thing, what do? We give oral medications. Okay, we give oral medications. So we said oral, let me just send that. We said the emergency is more than 220 over 110. How about the urgency? It should be more than what?
180.
Excellent. So it's been more than 180 over 100. And usually this is when you have like a good emergency medicine physician. They will take care of it. So you can do nitroglycerin patch. If there's a nitroglycerin patch, you just gotta remove the patch. That's the most important thing. Before you put the admit orders. That's the first thing. After that, you can do clonidine, PO, oral. Okay, and then you give what? IV medications. Okay, so that's basically with urgency. First, you give oral medication. Second, temporize, and third is observation. 3 things. Okay, oral medication, temporize, and IV medications. You can do IV medications like labetalol, some of these calcium channel blocker, phenoldopan, these types of things. So in a summary, if there's an outpatient management, we can do calcium channel blocker, venodilators, beta blocker. They all have anti-anginal benefits. The IC inhibitor for CHF and coronary artery disease. Arterial dilator, not so much we use it. Aldosterone antagonist also for CHF. Beta blocker also for CHF. So these are the benefits that with controlling hypertension can be used for other medical problems. The outpatient. Inpatient, we give clonidine, labetalol, or hydralazine. Okay. We try to drop it slowly to avoid ischemia to the tissues. And in emergency, we calculate the mean arterial pressure. We do nicardipine. We try to reduce the mean arterial pressure in 25% in 1 to 6 hours, and then we give oral medications. In urgency, we do clonidine and IV medications. Okay. And after we remove the patch, nitroglycerin patch, if they have one. And basically, that's the summary of high blood pressure.
Peace out.